Okay, good evening, everyone. So we'll just start with initiation and monitoring for the next 20 minutes. Hopefully, we'll be able to cover the entire aspect. So we'll start with initiation. So primarily, we need to understand that, initiation is a process and it's not switch on, switch off a mechanism. So it involves a lot of things. And the following things need to be considered when we initiate ECMO. A few of things have been already covered in the previous talks. The first thing is, of course, do we have the right indication, the right patient to start ECMO? The second thing is making sure that we have a proper consent, which is taken by the team, talking to the family members. The third aspect is, of course, preparation. So preparation is very, very important because we are dealing with a patient who is extremely sick and we are starting a treatment which is highly invasive. And doing it right is extremely important to get it right. So in terms of that preparation, we have to have a good patient preparation where, there is a team which is stabilizing the patient while the process of initiation is going on, stabilizing the breathing and circulation as needed, titrating the ventilation, titrating the vasoactive medication, ensuring that we have enough vascular access, anything that needs to be put in like arterial lines, central lines, putting an NG tube, urine catheter, all that needs to be done before we initiate, because once we go on heparin, then these, things become very complicated and risk of bleeding is very, very high. The second thing is, of course, the team. We need to have 3 teams working at the same time. One is a cannulation team, which will, take over the responsibility of cannulation, taking consent for cannulation and all that. Then there is a team which is looking at just preparing the circuit, priming the circuit and making sure they have the right components of the circuit in place. And then the patient team, like I said, who is trying to stabilize the patient. Then the right equipments, we need to have the right, cannulas, right consoles, circuits, oxygenators, all the systems that are required to, run the process of ECMO for this patient. That has to be decided based on what our endpoints are and what is it that we're trying to achieve in that particular patient. And then the location. Like Dr. Deepanjan said, that if you're doing central cannulation, you may have to take this child to the OT and do it. Well, if it is a peripheral cannulation, maybe it can be done at the bedside. Sometimes we do ECMO transports where we have to go to the site while we retrieve patients, and that may be the site where, we have to do the cannulation and initiate ECMO and bring the patient. So like that, a lot of preparation process goes on, and, it's a very tedious and laborious process. And if it is done right, then we get things correct. The fourth thing, of course, is cannulation, which already has been discussed, so I'll not go too deep into it. Anticoagulation also has been mentioned. So once usually when the guide wire is in, that's when we think about loading with heparin. Then circuit priming, we'll have to see what is it that we want in terms of type of circuit, the size of the circuit, the length of the circuit for ease of working, priming of the circuit. So that has to be decided depending on the physiological condition of the patient, whether the patient is anemic, whether the patient is in shock, whether the patient has hyperkalemia, is there metabolic acidosis. So many things go into deciding about how the priming solution has to be. We need to understand that priming volume is, very high among these circuits, be it adult patient or pediatric patient. So if the priming is not done properly, then that itself can lead to a lot of hemodynamic and metabolic disturbances. There will be stations during your workshop where it will be discussed about priming. It will be case-based discussion. So there you will understand these things much better. No, we should have a pre-initiation checklist to make sure that we get everything right. So make sure the cannula is secure and there's no bleeding or increasing hematoma at the site of cannulation. Make sure all connectors, ports, flow and pressure sensors are in place and well secured. There has to be a crash cart ready with emergency medications, because during the process of initiation, there can be a lot of, respiratory and circulatory disturbances. And make a note of the patient vitals as a baseline when you begin the initiation process. Then the cannula connections are done. The drainage cannula is connected to the venous side of the circuit, the return cannula to the arterial of the circuit. Slowly, the revolutions are initiated to start with a flow of about 10 to 20 ml per kg per minute, and gradually it is increased to achieve our endpoints of full flows. And then sweep gas is also initiated at, initially 0.5 to 1 ratio. I think we've had discussions about the importance of reducing the PCO2 gradually. We don't want to bring the PCO2 down drastically, which might, lead to neurological complications. During the process, look for chattering. The patient may need some volume replacements. in the form of crystalloids or colloids, and PRBC needs to be ready during this initiation process, because that is one important thing that can save lives. Monitor patient vitals at, in terms of saturations, mean arterial pressures, all those continuously during the process. Make a note of the RPM, how much flow is achieved, what are the P1, P2, P3 pressures that will come to later. And ACT will need to be checked to decide on when the heparin infusion needs to be started once the bolus is given. Common problems that are seen during initiation are hypotension, hypertension, desaturations. These are common things that can occur. Usually hypotension, when it happens, it's usually flow related. It may be because of the cannula positions, or it could be because the patient is hypovolemic. So you may have to, usually giving volume bolus, isotonic fluid bolus in the form of crystalloids or colloids, depending on the situation, might, help recover blood pressures in these patients. We may have to initiate or increase the vasoactive medications in certain situations. Hypertension is another thing that can happen during the process or immediately after. That usually happens because of the correction of the metabolic disturbance and improvement in the blood flows. And we may be on high vasoactive medications, and once the flow is restored and metabolic issues are corrected, then hypertension comes up, and we may have to quickly dial down on the amount of vasoactive medications that we are giving to prevent complications related to hypertension. Desaturation, again, in VV ECMO, it could be flow related, and improving flows, making sure there is good intravascular volume status, ensuring that the connections are proper. Sometimes in all the rush that we are doing when we are initiating ECMO in a rapid fire kind of a situation, somebody might have just forgotten to connect, or the tubing, oxygen tubing supply that is connected might have dropped off. So those are things that we have to be keenly watching. Loss of pulsatile flow, especially on VA ECMO, can happen once we go on full flows, because there's something called cardiac sunning that can come up, and then flow-related issues like I just discussed. So these are common problems that can come up during initiation of the ECMO. And let's come to monitoring on ECMO. So we have to understand that these are very sick patients, and they are dependent on ECMO in the early phase, definitely. So any kind of complications related to ECMO means that it may be an immediate threat to life. So that's why monitoring is extremely important, not only for the safety of the patient, but also for the safety of the circuit, and also to understand how the efficacy of therapy is over a period of time. So monitoring is an ongoing process. And like I said, these are very expensive treatments also. So safety of circuit also needs to be kept in mind, because we want to finish the ECMO run with one circuit, prevent the problems with anticoagulation. Prevent the problems with, clot formation and thrombus formation that can come in these kind of situations. So we need to maintain good anticoagulation, monitor the circuit continuously to ensure that, we are doing the right thing. So ECMO, we understand when a patient is on ECMO, that there are two circulations. One is the native circulation of the patient itself, and the ECMO circulation as well. And both the circulations need to be monitored, and monitored closely for the above mentioned reasons we just discussed. And the monitoring involves monitoring the patient vitals and perfusion parameters, and also lab parameters when it comes to native circulation monitoring of the patient. Let's start with patient monitoring. I'll start with head to toe in this situation, so that we don't miss out on issues, but not necessarily that this monitoring has to be in the same order. So coming to CNS monitoring, what we look for is the usual clinical parameters of consciousness, pupils, how the limb movements are we seeing any deficits that is new onset, how are the deep trend reflexes. So general monitoring, neurological monitoring is done, but it's very challenging in these patients, mainly because in the early phase, they're on neuromuscular paralysis. They're also on deep sedation to ensure that, the oxygen delivery and the requirement balance is well struck. So in those situations, we may have to use the help of technology in the form of, NIRS, transcranial Doppler, EEG, optic nerve sheath diameter, and all those things. CT scan is also something which can be done when patient is on ECMO, but that's something which is not very desirable, because it involves a lot of, precautions that we need to take. If moving a patient, it's not something which is done at the bedside. So moving a patient who's on ECMO for a CT room always is extremely risky. So we would like to use as much as possible technology that is available at the bedside, which is also, non-invasive, to be able to make those decisions. But in certain situations where we have to make a, important decisions about, continuing ECMO or considering other options, we may have to do a CT to be really sure about what we are dealing with from the neurological point of view. From the respiratory point of view, we usually monitor the usual respiratory settings. We spoke about the rest ventilator settings. So most of these patients who are put on ECMO, for VV ECMO, they go on rest ventilator settings. That varies between units. Different units have different policies of rest ventilator settings. So generally, we tend to do pressure control mode of ventilation with the rates of 10, PEEP of 10 to keep the lungs open. Peak pressures limited to 20 to 25 max, and FiO2 is dialed down as quickly as possible to safe limits of less than 50%. That's usually what constitutes rest ventilator settings. And when they're in rest ventilator settings and, we have to monitor for the lungs to be improving, the best way to monitor is see how the compliance is. And that compliance is reflected by the generated tidal volume for the same delta pressure, and also the end-tidal CO2 traces that we find on the monitor. So these things help us understand how the lungs are improving as well. Spontaneous breathing is something which can be permitted at a later stage, but usually in the early phases, maybe it is restricted. So we have to keep monitoring for those things. If somebody is breathing comfortably without increased work of breathing or generating excessive transpulmonary pressures, then spontaneous breathing is permitted in these patients. A lot of adult patients are over the first week of ECMO, when things are more stable from the ECMO circuit point of view and ECMO run point of view, they're even extubated. Some of them are even on BiPAP and other non-invasive supports, allowing spontaneous breathing to happen, which actually helps the lungs recover better and diaphragmatic functions and respiratory functions can be maintained. Oxygen saturation monitoring is very important. In VV ECMO, we are desirable to have our oxygen saturations anything above 88 to 90%, but we know that we accept even much lower saturations in VV ECMO, sometimes even up to 70% when we are having challenging issues with flows. The endpoint, of course, is how the end organ oxygenation parameters are. How is the lactate? How is the perfusion parameters, organ functions? Those are things that actually define whether we are having adequate oxygen delivery to the tissues. And when it comes to VA ECMO, we usually expect that their saturations are normal, and generally we monitor the saturations when it comes to VA ECMO in the right hand. And the reason for that is, we've had discussions about North-South syndrome. We'll come to that later. From technology point of view, we look at, chest X-ray and blood gases. Chest X-ray is primarily to look at how the aeration of the lung is improving. It's also to look at cannula positions. It's very, very important. Sometimes the cannulas can migrate, and that might be causing problems with flows. And if it is not monitored with periodic X-rays, we might miss out on it until it comes to a very extreme situation. Blood gases are periodically monitored to make sure the PCO2s are in normal ranges, the PO2s are good, the lactates are okay, and venous saturations are in acceptable limits. The North-South syndrome, as I said, we've already discussed about it. So the reason why we say that the right hand saturations need to be monitored is because that is the hand which directly gives us a clear indication about what is that saturation of the blood ejected from the heart in case the blood ejected from the heart is overcoming the perfusion force of the ECMO flow. And that usually happens when the heart functions are improving, but the lung condition is quite bad. And if we find the saturations of the right hand to be less compared to the other limbs, then we know that there is some differential saturation that is taking place. And if corrective measures need to be taken, that has to be undertaken. So this gives a very good indication about the North-South syndrome presence. If we miss out on monitoring the saturation of the right hand or doing a blood gas of the right hand, then we might completely miss out on identifying this condition. So it's very important to have the saturation monitoring in the right place. Now we'll come to circulatory monitoring. The usual parameters that are monitored are heart rate, rhythm, ensure that the patient is in sinus rhythm, the pulse, volume, peripheral temperature, all these are monitored. When it comes to VV ECMO, usually the pulsatile arterial trace is maintained because you're talking about a circulation which is in series. Unlike VA ECMO, where the circulation is in parallel, the pulse volume should be good. The peripheral pulses should be good. Peripheries should be warm. CFT should be okay when it comes to VV ECMO. In VA ECMO, sometimes you may not have good pulse volume. There may be a dampened race because here the ECMO flow and the cardiac ejections may be competing in the initial stages. Later, when the cardiac ejections improve and the cardiac condition starts improving, we'll have better pulsatility, and we can feel the pulses also better. In the absence of that and the presence of a damped flow, we go more by the mean arterial pressures and ignore the systolic and diastolic pressures on VA ECMO. And more important than that is, of course, as we have discussed in the past, what is that flow that we are getting for that pressure and how that flow is able to maintain a good cardiac output. And the indirect indices are, of course, looking at lactate, looking at venous saturation that tells us that this mean arterial pressure is sufficient for this particular patient. Generally, for adults, it's anywhere between 60 to 70 mean arterial pressures. In pediatrics, anywhere between 50 to 70, depending on the age group of the patient. Now, venous saturations, we've already mentioned about it. And there are some technological, tools that are available which can monitor the venous saturations on a continuous basis. So we don't have to do repeated venous gases, in order to understand the venous saturation. Along with the hematocrit, we get a reading of the venous saturation as a continuous thing when it is connected to the circuit itself. What you're seeing in the console is the venous saturation that is demonstrated as a continuous monitoring process. So this is where the venous saturation is monitored in the circuit. In the drainage cannula, it is monitored between the patient's drainage cannula end and also before the centrifugal pump. So that is where the venous saturation monitoring needs to be happening. So if the venous saturations are low, we need to understand that it can be because of excessive oxygen consumption, or it could be even because of inadequate oxygen delivery. So these are the parameters that we need to take into consideration. Look at sedation, look at breathing efforts, see if there is any other reason for oxygen consumption to go up, low hemoglobin, sepsis. So all these things need to be considered, and corrective measures need to be taken to address the venous saturation. So this is end-tidal CO2 monitoring. So it's a very important tool which tells us how, especially in VV ECMO, we come to know about how the lungs are improving as the tidal volumes. Initially, on VV ECMO, when we connect these patients on end-tidal CO2 monitoring, the amount of tidal volume that is getting in for their delta pressure is so less that we might not get a good trace. As we see that the lungs are improving and the tidal volumes are improving, we tend to get good end-tidal CO2 traces. So that helps us understand the adequacy of gas exchange and also of the pulmonary blood flow as well in these situations. And it helps very much during weaning from VV ECMO because then we can look at sweep gas flow and kind of correlate the end-tidal CO2 with the arterial CO2 and try to see if the sweep gas can be reduced. Vascular complications are quite common in a lot of situations, especially in pediatric age group where their vessels are so small and the cannulas are big. So we need to closely monitor the limbs, look for any discoloration, swelling, loss of pulse volume, coldness of the peripheries. That is the first thing that we can pick up. If the peripheries are cold, especially when there is differential temperatures, one leg is cold and one leg is warm, we need to quickly look at clinical examination, get a Doppler done. CT angio may be required in certain situations. And then corrective measures need to be taken to make sure that these things don't happen. GI examination monitoring is important. So how do we monitor GI is indirectly by looking at feed tolerance, looking at GI bleeding, presence of abdominal distension, intra-abdominal pressure monitoring may be required in a lot of situations. And of course, urine output also is monitored closely for looking at adequacy, not only adequacy of urine output, urine color. In the previous talk, it was shown how the urine color turned, cola colored because of hemoglobinuria. So those are things that will give us clues to very important and correctable things that need to be looked at while monitoring the urine output. Investigations, huge list of investigations. We don't have to remember and go by, very strict guidelines about doing everything 4-hourly, 6-hourly, or second-hourly. It has to be tailored to the patient requirement. Of course, the first initial 48, 72 hours when we are achieving stability from the ECMO and the patient point of view, we may have to do these investigations very frequently. to the extent that sometimes blood gases are done on an hourly basis to make sure that things are okay. ACTs are checked every 2 to 4 hours. So these investigations need to be spaced out as time goes on, depending upon the requirement of the patient, because cost of treatment also goes up significantly because of all those interventions that we are doing, the requirement of blood products. Some of these patients are on CRRT, so we need to have a judicious way of planning the blood investigations for these patients. So among investigations, few important things from the hematology point of view, we tend to keep hemoglobin in the range of 8 to 10, sometimes higher for VV ECMO patients, especially when we are having challenges with oxygen saturations. The platelets are usually maintained above 75 to 1 lakh in a bleeding patient, but in a patient who is stable, does not have any obvious bleeding manifestations, lower thresholds for platelet transfusions are accepted. ACTs are usually maintained anywhere between 160 to 180, sometimes up to 220, especially when they're on CRRT as well, just to make sure that the clotting functions are addressed and there is no complications related to formation of thrombus and all that. TEG is not something which is done on a routine basis, but if you're having challenges with coagulation problems, either in the form of excessive thrombus formation or more so in terms of bleeding complications, then TEG-based direction towards use of specific blood products can be utilized, which is very, very helpful instead of blanket throwing all the blood products that are there in the armamentarium. Electrolytes and organ functions need to be monitored periodically. Important to keep the important electrolytes, calcium, potassium, magnesium, phosphorus, all within normal limits. Periodic monitoring of liver and renal functions will tell us about any problems happening in those organs because of hypoperfusion. Blood gases, like I said, we need to monitor periodically. And monitoring for hemolysis, very important. Whenever we have a dark or cola colored urine, look for plasma-free hemoglobin. And if it is less than 10, it is normal. If it is high and elevated, think about hemolysis. We may have to reduce the flows. We may have to sometimes change the oxygenators if nothing is working, because that usually happens because of excessive flow or because of clots in the oxygenator that is causing the hemolysis. Sorry. Monitoring for sepsis is very challenging in these patients because these patients don't manifest with the usual, sepsis parameters. The temperature is well controlled and, well regulated in these patients. So just excessive needs of fluids and increased requirement of vasoactives, new onset tachycardia. So we have very subtle features which will tell us which will give us a hint that this patient may be septic. Unexplained drop in platelets is another thing, but then platelets can drop when patients are on ECMO because of various other reasons, if they're on CRRT and so many other things. So monitor their white cell count, CRP, procal. Again, a trend of these investigations will give us a better picture rather than absolute numbers. So we have to do surveillance cultures in these patients and start antibiotics, and then think of de-escalating at a later time if things are not strongly indicative of sepsis in these patients. Role of echocardiography, we be looking at the cannula position, making sure the right heart function is okay, looking for other features that can cause poor flows like pericardial effusion, especially if they have central cannulation. So, and in VA cannulation, when we are weaning patients off ECMO, looking at the cardiac functions, how is the heart, and also when the ejection is not good, to understand whether there's any cardiac distension. Does the patient need venting of the LV? So all these decisions can be helped by looking at echocardiography itself. Most of the times we end up doing transthoracic echoes, and in some centers they still do, transesophageal echoes also if there are challenges in understanding the position with transthoracic echoes. X-rays, like I said, for cannula positions and assessing the lung status, whether there's development of any pulmonary edema, effusions, all these things are helpful by doing periodic X-rays. Let's come to circuit monitoring. So first thing is to check on a daily basis to make sure the cannulation site is okay. There is no bleeding, hematoma formation, no signs of infection on these sites. So transparent dressings are put so that the inspection can happen without removing these dressings periodically. At the same time, look for any kinks in the circuits, look for any clots in the circuit or oxygenators. Especially the clots can happen wherever there is additional attachments in the circuits, like a three-way cannula all these things. And oxygenators are another source where, clots can form. So daily you'll have to go like a watchman, put your torchlight on these circuits and look for adequacy of flow and look for all these features to make sure that the circuit is healthy. Other thing, we look at pressures. There are, 4 important pressures that we monitor. They're called as P1, P2, P3, and then the delta pressure. We'll start with the P1 pressure. That is usually the pressure that is recorded pre-pump pressure. That is before the, blood pump. And because it is connected in the, drainage circuit, it's because the suction action of the pump, these pressures are usually negative, anywhere between -20 to -70 range. And excessive negative pressure pre-warns us that there could be problems with the flow. And that can be because of either cannula position changing or hypovolemia is the commonest reason. Or the cannula could be size-wise small compared to what is required. Or there could be kinks in the circuit that may be causing excessive negative pressure. All these corrective measures need to be taken up in order to make sure the flow is good. Chattering in the circuit is sometimes a late manifestation. So the monitoring the pressure will help us understand the process much earlier than chattering. So this is how the P1 pressure is, shown on the screen. You can see the circle number -11. So that is the P1 pressure that is shown on the console. P2 circuit is the pre-oxygenator pressure, that is after the pump and before the oxygenator. It records a post-pump pre-membrane pressure. There's no fixed value. It is usually positive and can go up to +350 to 400. And what factors modify this is the pump speed, how much flow is we are getting, and what is the resistance in the distal part of the circuit, that is in the oxygenator or in the patient's arterial system. So these may cause elevation of the pre-oxygenation pressure. Now the third pressure, the P3 pressure, is the post-oxygenator pressure. Again, there is no fixed value here, and it depends on a few things. The most important thing is the SVR of the patient and also the pump flow. So if the SVR of the patient is high, and then you normally see that the amount of pressure that is required to pump blood is high, so that is when the post-oxygenator pressure will also go up. Then we have something called delta pressure. It's a very important parameter which actually tells us directly about the functioning of the oxygenator. So whenever there's a difference in the P2, P3 pressures, which is very high, then that tells us that there may be, the oxygenator may be developing clots and the resistance to the oxygenator is very high. Again, there is no fixed number. We'll have to go by which oxygenator is being used. Some oxygenators are, show very high resistance. Some oxygenators show least resistance. So whenever we start the patient on ECMO, we monitor and record what is the baseline delta pressure. And if the delta pressures are rising, the trend in delta pressure is more important rather than absolute numbers for us to understand whether there's a problem happening. And of course, we monitor the RPMs and flow. So we need to keep an eye on at what RPM, how much flow we are getting, because that will tell us a lot, give us a lot of information about the preload status of the patient, the cannula and the status of the patient, the afterload of the patient. So for the same RPM, if I'm getting higher flows, that means the flow is improving. The preload may be improving, the afterload may be reducing. But the same RPM, I'm getting lesser flows, then there could be a problem with the preload and the afterload. So that's how the RPM and the flow are related. Gas flow rate. Sweep gas flow rate is usually set at 0.5:1 to begin with. We can go up to maximum of 1.5:1, depending on how much the CO2 levels are. And we have to titrate to carbon dioxide levels. And in the early phase, we generally tend to start at low sweep gas flow because we don't want the CO2 to drop too quickly. Especially if the beginning point of ECMO, there is hypercapnia, significant hypercapnia, say more than 50 to 60. So we have to be very careful to titrate the sweep gas flow to reduce the CO2 very, very gradually. If there is hypercapnia, we may have to increase the sweep gas flow. So take-home messages: ECMO is a life-saving, complicated, intervention, and things can go wrong. And prevention and preventive actions are better than reactive actions. So monitoring them closely will help us understand if something is going wrong much earlier than, picking up things when they go wrong. So it's important to monitor them very closely. Safety protocols need to be followed strictly. And monitoring is also important to look at response and progression of the physiology. And lab investigations in imaging are important, but then we have to titrate it to patient requirements, and we don't have to go by fixed, plan of monitoring every 2 hours, every 4 hours in that kind of a, process. So ECMO monitoring, in short, is hours and hours of boredom interspersed by moments of stark terror, and prevention is better than cure. Thank you very much.